Welcome to our video on gastric malignancies. Let's begin. Here is an overview slide of the following gastric malignancies that we will be discussing in this lecture. We will be discussing three disease processes: gastric adenocarcinoma, gastric lymphoma, and gastrointestinal stromal cell tumors. In each case, we will be discussing the definition, risk factors, clinical features, diagnosis, and treatment. Let's begin with gastric adenocarcinoma. Let's discuss the definition of gastric cancer. Gastric cancer is most commonly a gastric adenocarcinoma. Recall from pathology, there are two histological types, the intestinal and the diffuse type. Remember that lesions seen in the intestinal type are more ulcerative. Lesions seen in the diffuse type are thickened and carry a poorer prognosis. The thickened appearance of the gastric wall is referred to as linitis plastica. There are multiple risk factors for gastric cancer. These include lifestyle factors such as ingestion of large amounts of food containing nitrosamines, which are commonly found in smoked foods, and cigarette smoking. H. pylori and chronic gastritis leading to intestinal metaplasia are also major risk factors. Other risk factors include gastric ulcers and gastric polyp. Cases of gastric cancer have also been found post-partial gastrectomy surgery. Now let's discuss the clinical features seen in patients with gastric cancer. Gastric cancer often presents late with nonspecific symptoms such as involuntary weight loss, abdominal pain, and early satiety. Lesser Tourette sign is a rare skin disorder in which multiple seborrheic keratosis appear suddenly on the body, which can be a cutaneous paraneoplastic syndrome associated with a malignancy. Acanthosis nigricans can also be seen, but it is not specific for gastric malignancy since it can be seen in other conditions. It will present as the sudden appearance of dark, velvety discoloration in body folds and creases. Signs of upper gastrointestinal bleeding like hematemesis or melena can also be present. Melena is stool that is commonly described as sticky and dark as it's mixed with fecal contents and partially digested blood. Let's take a look at this image. In this axillary area, we see a dark and velvety discoloration within the creases and folds. This is called acanthosis nigricans. This physical exam finding can be associated with gastric cancer. However, it can also be present in a number of other conditions such as polycystic ovarian syndrome and is not specific to gastric cancer. On this slide, the patient's back is filled with flat macules and raised hyperpigmented lesions in clusters. This is called seborrheic keratosis. This skin finding can be seen in the elderly and can be benign. However, the sudden eruption of seborrheic keratosis may raise suspicion for gastric malignancy and is known as the lesser Tourette sign. Gastric cancer can also present with signs of metastasis. A Virchow node presents as left supraclavicular lymphadenopathy. Direct seeding of gastric cancer to the ovaries, usually bilaterally, is referred to as a Krukenberg tumor and consists of signet cells seen on histology. Gastric cancer can also metastasize to the periumbilical lymph nodes. This can manifest as a palpable nodule protruding from the umbilicus and is known as a Sister Mary Joseph nodule. Finally, patients with metastasis to the pouch of Douglas can present with Bloomer shelf sign, which refers to a mass felt on digital rectal examination. Here's an image that will be helpful to visualize the different locations of metastasis in gastric cancer, which were discussed on the previous slide. The green dot on the left clavicular area represents the Virchow node. In the periumbilical region, the dotted brown dot illustrates the Sister Mary Joseph nodule. Krukenberg tumors are represented by the two solid brown circles. Within these blue circles are an example of what signet cells look like on histology. The nucleus is pushed to the periphery by large vacuoles of mucin, giving off a resemblance of signet rings. Signet cells are a characteristic histological finding of Krukenberg tumors, which are the metastasis of gastric cancer to the ovaries. When gastric cancer is suspected, an upper GI endoscopy with multiple biopsies is necessary in order to confirm the diagnosis. The intestinal type usually affects the lesser curvature of the stomach. It typically presents as an ulcer with raised margins. The diffuse type can be found anywhere in the stomach, and the mucosa is described as thickened and leathery. Once the diagnosis is confirmed, an abdominal CT scan is obtained to evaluate for metastasis and to stage the disease. Here is a gross image of adenocarcinoma of the stomach in a gastrectomy specimen. Notice the fungating, ulcerated surface with heaped up borders that is obstructing the gastric lumen. These gross findings are most commonly associated with the intestinal type. Here is a gross image of adenocarcinoma of the stomach in a gastrectomy specimen. Notice the plaque-like lesion and the fibrous thickening of the stomach wall, making it look like a leather bottle. These gross pathologic findings are most commonly associated with the diffuse type of gastric cancer. Management depends on the stage of tumor at the time of detection. Endoscopic resection of the tumor can be done when tumors are detected in the early stages. However, the definitive treatment for more advanced tumors is gastrectomy with lymphadenectomy. Roux-en-Y bypass is an option after gastrectomy to prevent gastrointestinal obstruction. Chemotherapy can also be used and may be given before or after surgery. Let's take a look at this image above showing the approach taken when performed Roux-en-Y surgery. After gastrectomy, Roux-en-Y surgery can be performed in order to form a new digestive tract after removal of a portion of the stomach. Seen on this image is the distal end of the esophagus or the remaining part of the stomach. This part will be connected to the small intestine, establishing a new passage for food. A 54-year-old immigrant from China presents to the clinic with 3 months of abdominal pain and dyspepsia. Physical exam is notable for epigastric pain, mild hepatomegaly, and a palpable nodule just above the left clavicle. Initial lab evaluation is notable for a hemoglobin 8.2 and MCV of 74. What is the next best step in diagnosis? The next best step in diagnosis would be to refer this patient for upper endoscopy, and there's a high chance that this patient may have a gastric cancer. Recall that gastric cancer is particularly prevalent in Eastern Asia, Eastern Europe, and certain parts of South America as a result of diets rich in carcinogenic nitrosamine compounds. Additionally, findings of epigastric pain in conjunction with mild hepatomegaly and the Virchow node should always prompt suspicion of gastric cancer. Lastly, findings of a microcystic anemia on initial laboratory evaluation is also highly suspicious of and consistent with a diagnosis of gastric cancer. Hence, this patient needs to undergo endoscopy and all suspicious lesions must be biopsied and sent for analysis. Now that we have covered gastric adenocarcinoma, let's move on to gastric lymphoma. We will be discussing the definition, etiology, clinical features, diagnosis, and treatment of gastric lymphoma. Gastric lymphoma can be one of two types of lymphoma. One type is a diffuse large B-cell lymphoma. Another type is malt lymphoma, which is a lymphoma arising from mucosa-associated lymphoid tissue. Chronic H. pylori infection is the most common cause of malt lymphoma. Let's discuss the clinical features that we may see in patients with gastric lymphoma. Gastric lymphoma presents similarly to gastric adenocarcinoma with involuntary weight loss, abdominal pain, and early satiety and melena. Physical exam is often unremarkable. Now let's move on to the diagnostic methods for gastric lymphoma. Endoscopy with biopsy is performed to identify a potential H. pylori infection or to confirm the presence of malignancy. Histopathology findings show thick infiltrates of lymphoid cells, while immunochemistry reveals immunologic markers of B cells, such as CD20. After endoscopy with biopsy, a CT or MRI is used for tumor staging. The treatment for gastric lymphoma includes treating the H. pylori infection if present. Especially in early stages, eradication of H. pylori infection can be sufficient in treating malt lymphoma. Treatment includes triple therapy or quadruple therapy. Triple therapy includes amoxicillin, clarithromycin, and proton pump inhibitors. On the other hand, quadruple therapy is provided in cases of penicillin allergy. This is comprised of macrolides, tetracyclines, bismuth, and proton pump inhibitors. In a minority of patients, H. pylori test turns out negative, or their lymphoma is unresponsive to treatment of H. pylori. In such cases, the recommended treatment includes local radiotherapy. Chemotherapy is used for refractory cases. One of the most frequently used agents is rituximab. Recall that the mechanism of action of rituximab is to inhibit CD20, which downregulates the B cells that cause tumor burden in gastric lymphoma. So let's read a question. A 55-year-old female presents to her primary care provider to follow up on results of a biopsy of a 3-centimeter mass in her stomach. The biopsy report notes a lymphoma arising from the mucosa-associated lymphoid tissue. What is the next best step in management? A lymphoma arising from the mucosa-associated lymphoid tissue is the description of a malt lymphoma. All patients diagnosed with malt lymphoma must be tested for H. pylori infection, as it is present in about 90% of patients with malt lymphomas. Interestingly, early-stage malt lymphomas can be treated solely by eradicating the H. pylori infection. which is why this association is so high yield for the boards. Finally, let's discuss gastrointestinal stromal cell tumors. We will be discussing the definition, pathophysiology, clinical features, diagnosis, and treatment of gastrointestinal stromal tumors. Now let's discuss the definition of GIST. Gastrointestinal stromal tumors can arise anywhere throughout the gastrointestinal tract, but are most commonly found in the stomach. GIST usually arises from the interstitial cells of Cajal in the stomach. These cells are considered the pacemaker cells of the GI tract and help with peristalsis. Let's move on to the pathophysiology of GIST. The pathogenesis of GIST tumors is believed to be associated with activating mutations in the c-KIT proto-oncogene, which is a transmembrane receptor tyrosine kinase. Recall from pathology that activation of this oncogene eventually leads to tumorigenesis. Clinical features of GIST may be similar to other malignancies, but they are still noteworthy to talk about. Gastrointestinal stromal tumors can be asymptomatic or present with nonspecific symptoms such as bloating and early satiety. They can also present with abdominal pain and melena. Now let's focus on the diagnostic methods we can use to confirm this disease. Contrast CT is the imaging of choice. With intravenous contrast, the tumor is enhanced and appears as a solid, smoothly contoured mass. Necrosis and hemorrhage may also be seen on MRI of larger tumors as the tumor outgrows its blood supply. Immunochemistry and histopathology are used to confirm the diagnosis. c-KIT receptor analysis can also be done when GIST is suspected. While there are many markers for this tumor, c-KIT is frequently asked on the board exams. A positive result will help properly manage the treatment for patients with this disease. In this image, notice a homogeneous solid mass with smooth margins located on the posterior wall of the stomach on this abdominal CT scan. This is a confirmed case of GIST. Now let's take a look at the image above. This image shows a slide of GIST under immunochemistry for c-KIT, which is a proto-oncogene commonly associated with GIST. The brown color on the slide indicates the presence of c-KIT. Let's end this lecture with the treatment of GIST. GIST tumors can be resected if they are localized. Since these tumors are often a result of mutations in c-KIT proto-oncogenes, c-KIT tyrosinase kinase inhibitors are used to treat the tumor. Imatinib is one of the c-KIT tyrosine kinase inhibitors that can be used. Sunitinib, another c-KIT tyrosine kinase inhibitor, is used as an alternate choice for refractory disease. Let's read another question. A 67-year-old male with a history of osteoarthritis presents to his primary care provider with 4 months of intermittent abdominal pain and heartburn. He describes the pain as burning and localized just above his belly button. He says the pain often gets worse soon after he eats. He says he's never had anything similar before. He takes ibuprofen daily for a bad knee. His blood pressure is 139/75, pulse is 75, temperature is 37 degrees Celsius, BMI is 26, which is down from 29 during his prior clinic visit 4 months ago. Abdominal exam is notable for mild tenderness to palpation in the epigastric region. Rectal exam is unremarkable. In addition to the laboratory workup, which of the following options is the next best step in management of this patient? A. Order a urea breath test. B. Initiate omeprazole, amoxicillin, and clarithromycin. C. Refer for upper endoscopy. D. Order a stool guaiac test. The correct answer is C. Refer for upper endoscopy. This is a case of a patient presenting with burning epigastric pain that worsens after eat, which is suggestive of peptic ulcer disease. However, this 67-year-old patient also lost a significant amount of weight since his prior visit, that his BMI has decreased from 29 to 26. His old age and unintentional weight loss are concerning for underlying malignancy, which would be best evaluated with upper endoscopy. A urea breath test can be ordered to test for the presence of H. pylori infection. Unfortunately, this patient's high-risk features of old age and weight loss warrant an assessment for cancer, not just H. pylori infection. Since endoscopic biopsy of a presumed gastric ulcer can be diagnostic of both cancer and H. pylori infection, it is preferred over the urea breath test, so option A is incorrect. Option B describes the triple therapy that can be employed in eradication of H. pylori infection. This option is incorrect because we must first evaluate this patient for the presence of cancer. Lastly, option D would determine whether this patient is experiencing occult gastrointestinal blood loss. Though somewhat useful, the diagnostic yield of a stool guaiac test pales in comparison to the diagnostic yield of an upper endoscopy in a patient with presumed gastric cancer, which is why option D is incorrect. This concludes our lecture on gastric malignancies.